In terms of using Brigatinib, Brigatinib is approved after progressive disease or intolerance to Crizotinib as second-line treatment. And for that, it's shown to be effective with high response rates and a median progression-free survival ranging from about 12.9 to 16 months. It also has intracranial responses and excellent CNS activity, where it can be used in patients who have asymptomatic brain metastases without resorting to whole brain radiation and other things that after a certain amount of time can develop long-term toxicity, since these patients with ALK-rearranged non-small cell lung cancer are living longer and longer with the development of Brigatinib and other next-generation ALK inhibitors. Now the standard has evolved where alectinib is approved for first-line use for ALK-rearranged non-small cell lung cancer. The standard of care upon progression on alectinib is generally platinum-based chemotherapy. There are some mutations that mediate ALK-dependent resistance. There's several of them that are shared with alectinib and Brigatinib, but looking at preclinical data, there's several that may be sensitive to Brigatinib where that could be considered upon progression with alectinib. However, that's not FDA approved or standard. In particular, the G12R2R mutation appears, at least preclinically, to have intermediate resistance to Brigatinib, so other ALK inhibitors are in development looking at that as well. And I eagerly await reports of activity of Brigatinib after alectinib and think that should be studied further in clinical trials based upon the evolution of treatment of ALK-rearranged non-small cell lung cancer. And I eagerly await the results from the first-line Brigatinib study to see how effective it is in the ALK inhibitor naive setting and to see if it could at least meet, if not exceed, the excellent progression-free survival on average greater than 30 months that we're seeing with alectinib. The expectations for this patient who initially received Crizotinib for her ALK-rearranged non-small cell lung cancer, had an excellent response and then developed progression. I would expect Brigatinib to give a high probability of having a good response to treatment, including within the central nervous system based upon data presented by Dr. Huber and colleagues that we discussed previously from the ASCO abstract. I would also expect them to do well with an on-average progression-free survival or time for things to progress of between 12 and 16 months. Upon progression, some of the things I think about doing, in addition to considering standard platinum-based chemotherapy, would be, if it's oligo progression, consider radiation, focused radiation and continuing Brigatinib, or biopsying the tumor, for example, looking for that G12O2R mutation that you can match potentially to like a clinical trial, such as lorlatinib or other mechanisms of resistance that may inform clinical trials and future treatments for the patient. The future treatment of ALK-positive lung cancer, I think, is bright. We've made unprecedented advances in the treatment of ALK-rearranged lung cancer, as evidenced by the high response rates we're observing with next-generation ALK inhibitors, the data that was presented with the exceptional median progression-free survival on alectinib. I hope in the future we develop tolerable combination strategies to treat patients up front to even make more strides in treating ALK-positive lung cancer, where we've already had great successes, but we need to always do better.